Welcome to our Lunch and Learn webinar series presented by Partners in Senior Care. We're happy to have you all here. So our presenter today is Tricia Minoni, founder of family-owned Partners in Senior Care. Partners in Senior Care provides caregivers and care managers to help their loved ones. Tricia has over 20 years helping families navigate the aging journey. So at this time, she's going to present to us on the topic of My Mom Isn't This Way at Home. Is it dementia, delirium, or am I in denial? Just one moment, and Tricia, go ahead.
Thanks so much.
Thanks so much, Angie. It's good to be with you all again. Everybody's heard about dementia, but most adult children haven't heard about delirium in seniors. And it happens more often than you think, and it is often misdiagnosed. Why? Well, simply put, professionals often do not listen to the adult child when he or she says, "Mom isn't like this at home." Or 2 weeks ago when Mom and I went out to lunch, she was fine, and now she's so confused. The adult child is assumed to be in denial of the fact that Mom has dementia. So let's look at the difference between delirium and dementia. Both diagnoses present as confusion. That is the inability to process or retain information. But there are some very real differences. Delirium has a rapid or sudden onset. Remember the two things? Mom was fine 2 weeks ago at lunch. Before Dad was hospitalized, he was balancing his checkbook. Now he doesn't know what day it is. Dementia, on the other hand, develops over a long period of time. Mom forgets where she puts the keys. She forgets to get dinner started on time. And then it's Mom got lost when she went to the store. But all of that doesn't happen overnight. That happens over a 2-year span, from losing our keys to getting lost coming home from the grocery store. In delirium, the symptoms will fluctuate. The memory might be good in the morning, and by night it's not so good. A scenario: we talked about what to buy Sarah for her birthday over breakfast. And by dinner, she forgot Sarah's birthday was next week. Then you show her you bought a scarf for Sarah, and it all comes back. In dementia, memory stays fairly constant through the day. Mom forgot Sarah's birthday was next week. We talked at breakfast, decided to buy her that scarf. At dinner, I showed her the scarf, and again, she didn't remember the birthday. So again, what was lost stays lost in dementia. Delirium may also cause hallucinations, changes in sensation and perception. Don't always see hallucinations in dementia. So that's a really big sign that it's delirium rather than dementia. Another important thing to remember is that delirium is a symptom. Dementia is a disease. As a symptom, it may be indicative of an underlying medical condition. Let's talk about some of the causes of delirium in the elderly. You'll have to excuse me, I have a bit of a cold today. Infection generally, so what are the causes of delirium? Infection generally presents with a fever in you and I, but as we age, our thermoregulator system changes. That's why Grandma is still wearing her sweater in the summer. It also means she probably won't run an elevated temp with an infection. Urinary tract infections in women usually present with frequent urination, burning sensation, not necessarily with older women. My mom used to hear babies crying when she had a UTI. She'd call my sister and simply say, "The babies are crying again." They would laugh, and my sister would make the doctor's appointment. However, the first time it happened, it was very frightening for both of them. Hallucinations are not fun. Next cause of delirium, metabolic imbalance. Our bodies must be in balance to be in harmony. Low sodium or low calcium can cause an imbalance and can lead to delirium. It can lead to confusion. Malnutrition or dehydration also can lead to delirium. You think of people that are in a starving situation in prison camps. They suffer from confusion, hallucinations, etc. Sometimes you think, gee, Mom's been so confused since Dad died. She's really depressed. Well, is she depressed? Or is she not eating well and suffering from malnutrition and now suffering from delirium? So look at the whole picture. What are the causes? It might be depression. It might be delirium because she's just not eating right. Medications. Many medications have side effects that will lead to delirium in seniors. Some of those medications are pain meds, sleeping medications, Parkinson's medications, and medications that treat anxiety and depression. So Mom is depressed because Dad died. We now give her an antidepressant. She's not eating well. She's on an antidepressant, and now she's into delirium. Alcohol can lead to confusion and delirium. We know that simply by looking at how people act when they drink alcohol. But as we age, we metabolize alcohol differently. We metabolize it more slowly. That's why alcohol consumption needs to decrease as we age, and oftentimes during retirement it increases. People are socializing more, therefore they're drinking more. So, simple rule of thumb, teenagers and teenagers should not drink, but we probably won't stop either one of them. Hospitalization, especially if the hospitalization begins in the ER or involves the intensive care unit, can cause delirium. And we'll talk more about hospitalizations. So what's happening and what can you do to help? All right, what are the signs and symptoms? Unable to focus, withdrawn. You see that picture. Mom's just holding her head. She's just not quite sure what's happening. She can't focus on the conversation. She maybe is answering inappropriately. She appears confused. She might be having hallucinations like my mother, who would hear babies crying. Sometimes that is, I just feel lazy today, except that laziness goes on for several days. I'm just feeling off. I don't know what's the matter, Susie. What about that confusion? Forgetting about what was talked about in the morning. So that's what's happening. What do you do about it? We don't quite know what the cause is, but we're seeing some symptoms. Well, I own a home care agency, and I'll get phone calls from adult children. Mom was fine last week, and now she's so confused. She must have dementia. I can't leave her alone. How soon can you get someone? I need to get home to my own family. When we get those phone calls, the very first thing we tell them is, did this confusion happen suddenly? Yes, she was fine 2 days ago, and now she just doesn't know. She's not dressed. She doesn't know what's happening. I can't believe this. First thing we say to them is she probably has an infection. Call your doctor or go to urgent care, get a urine specimen and see if she has a urinary tract infection. If it's in the wintertime, we say she might have pneumonia. And so they make the doctor's appointment. A urine specimen will reveal if there's a urinary tract infection. The doctor's going to listen to the lungs, and that will reveal if there's a possibility of pneumonia, and they'll get a chest x-ray. Routine lab work, just a simple draw some blood, look at calcium, look at the sodium, will reveal if there's a metabolic imbalance. Last but not least, the doctor's going to ask what medications they're on, both prescription and over the counter. If your loved one's seen several doctors, which is not unusual, cardiologist, neurologist, and primary care doctor, maybe there's some interactions that are happening between all those different medications. So that needs to be looked at. Are the medications interacting? Can the dose be reduced? Is the medication still necessary? I cannot tell you then how many times after that initial phone call, family members call us back and say, I took him to the doctor. It was a UTI. How did you know? We know because we see it all the time. We deal with seniors. So what about hospitalizations? This is a really big one. And this is where the adult child gets figuratively patted on the head and told they are in denial that mom has dementia and needs to be placed in a facility. The reality is 70% of all intensive care unit patients will develop delirium. It used to be called intensive care psychosis. 33% of hospitalized seniors will develop delirium. That's 1/3. Even 16% of those that go to rehab units after a hospitalization will suffer from delirium. Those are pretty big numbers. Why does all this happen? Well, it doesn't take a rocket scientist or a degree in nursing or medicine to figure this out. What causes confusion or delirium? Sleep deprivation. Well, has anyone ever gotten a good night's sleep in a hospital? Your vital signs are often taken several times during the night. The halls are noisy. And if your hospitalization starts with a trip to the ER during the night, there has been no sleep for 24 hours by the time you get into your room. In the case of seniors, many of them are wearing hearing aids or glasses. They don't bring them into the hospital because the last time they went in the hospital, they got lost and it cost them a lot of money to replace them. So this time they don't bring them in. If you cannot hear or see well, you will answer inappropriately and you will become disoriented and confused. Medication side effects. Two big ones that cause confusion are sedatives and anesthesia. So if you're in the hospital to have surgery, you're having anesthesia. It takes a 35-year-old to 45-year-old at least 1 to 2 days to become defogged after an anesthetic. How long do you think it takes your 80 or 90-year-old mother to? So surgery equals anesthesia and it equals confusion. But what about sedatives? How often does the senior say, gee, I was awake all night, it was so noisy, give me a sleeping pill tonight? Guess what? That sleeping pill is going to lead to the possibility of delirium. People get put on new medications in the hospital. Maybe they're having a reaction, a side effect to a new medication. Maybe it's interacting with another medication. Maybe it's the wrong dose. So you need to be questioning those new meds. Change in environment leads to confusion. The lights from the hospital parking lot can be shining into the window. Your mother might say, I never sleep well without Dad next to me. I couldn't find my way to the bathroom. The room was so dark. All of those things lead to confusion. So what can you do to help your loved one? Well, I always say to people, would you leave your child alone in the hospital? And the answer is always no. At some point, maybe when they're 13, 14, 16, mom feels safe enough leaving them alone. She doesn't leave the 2-year-old. She doesn't leave the 5-year-old or the 8-year-old. So why do you leave your 80 or 90-year-old parent alone? Stop and think about it. They need to be kept oriented. That means glasses and hearing aids, even though they might get lost and you have to replace them. You need to normalize the environment. You need to visit often. You need to bring newspapers. You need to help them figure out how to use the TV, whose controls are in the side rail on the bed. These are new things, and they need to be oriented to that to know how to work it. Bring some pictures from home. That gives them some familiarity. The other thing that it does is it encourages the hospital staff to comment on them and to talk to your parent and ask them questions and see that they really do know what's happening. Bring the book from their bedside. That's much better than a sleeping pill, and that's how they normally fall asleep. You need to be your parent's advocate. Question, question, question. Why does she need this sleeping pill? What is the purpose of this new medication? What are the possible side effects? How will this new medication interact with the meds she's already on? Are we replacing the medication, or is this totally new? Remember we talked about hydration and nutrition? We said that dehydration and malnutrition lead to confusion and delirium. Well, guess what? Eating in bed is not easy. Is someone helping your parent get into a chair to eat breakfast, lunch, and dinner? What about opening those containers? You know, you get the cream in a little container. Mom has arthritis. She can't open it up. She can't put the cream in her coffee. Therefore, she doesn't drink her coffee. Therefore, she is not hydrated. Maybe by the time the tray gets brought there, it's cold. Is anyone taking it back and rewarming it in a microwave? Hydration. Mom's sitting in bed. She now has a pitcher. She's got to pour her water from the pitcher, and she spills it all over herself because it's hard to pour a pitcher when you're slouched down in bed. Who's helping her? Nobody. So she's not eating right, she's not drinking right, and now she's confused. So get mom up in chair for meals if it's allowed. Reduce the external stimulation. Close the drapes at night. We don't need the parking lights shining in. Maybe mom's hospitalized in the city and she's a country girl. Boy, all those lights from the city are going to be a whole different perception to her when she wakes up in the middle of the night. So pull the drapes. During the day, are there only overhead lights shining into her face? Is there any way we can turn those off and soften the lights in the room? Lots of noise out in that hall. Can we close the bedroom door so it's not quite so noisy? I've been very impressed lately. Some of the new hospitals or renovations have put side windows next to the door so that the night personnel can simply open a shade on the outside, look in and check on the patient without having to open the door and wake them up. Makes it a whole lot better. Now, what about when we're transitioning home? And I always say to people, always have return to home as the goal. That's where everyone wants to be. And I define home as where mom lived before the hospital. That could be a senior living community like my mother-in-law. She has their own apartment. They do the housekeeping. She walks down the hall and goes to her meals. It's safe, it's secure, but it's independent. Or it could be an assisted living facility. But it is her home. And home is where I lived before the hospital. Home is where my stuff is. And home is where I'm always going to do the best. Delirium often corrects itself when mom gets back to her familiar territory. And home is familiar surroundings. It's your furniture. It's your pictures. And it's your routine, not somebody else's. Always reassure and reorient your loved one if there have been a lot of changes. Let her know that she will have extra help as long as she needs it to feel comfortable. That might mean paying a caregiver or enlisting family members for the extra support that's needed. Let me tell you what happened in our family. Last July, my 96-year-old mother-in-law, who's alert and oriented and lives in a senior living community, was hospitalized for acute onset shortness of breath. It was pretty frightening for her. It was frightening for her son that was with her, and she was admitted to the hospital. She was started on oxygen. Lots of things were changing. And really and truly, the family was worried. She was worried. Was she having a heart attack? What was happening? Well, we left it to the doctors to be running the tests. But we knew we had to be there to reassure her so that she wouldn't become confused or frightened. So either my husband or I stayed with her from 8 o'clock in the morning until 4 o'clock every day. Her other son, who lived in the city, stayed with her from 4 o'clock in the afternoon till 9 o'clock at night. And we paid a caregiver from 9 p.m. to 7 a.m. I say we. Really, it was her out-of-town daughters that picked up the bills. One said, we need to fly in, we need to fly in. I said, she's not dying, but we need someone to stay with her during the night. Instead of paying for the airline ticket, how about if you each pay for the caregivers? So that's what they did. Well, after 3 days, it was determined that she had congestive heart failure. She's 96 years old. Things are slowing down. She was on some new medications, and she will be on oxygen for the rest of her life. She had remained oriented during her hospitalization, although she was very repetitive to have things explained and re-explained to her, which is why I was always there to hear what the doctor had to say. So she didn't get it confused. So I repeated it to her. So she went home with those new meds and on oxygen. Those of you who aren't familiar with oxygen, meant she had 40 feet of oxygen tubing on the floor so that she could reach every area of her apartment. Well, oxygen tubing on the floor and a 96-year-old with a walker is a fall waiting to happen. She was also on a diuretic, which meant she'd be urinating more often. So we put in a live-in caregiver for 5 days. And then we reduced the caregiving from 9 a.m. to 5 p.m. for 5 days. So she had help for 10 days. And that gave her a chance to get used to the oxygen, how to put it on, how to not trip on the tubing, little extra help going down the hall to her meals in the dining room. and then she was on her own. Well, not completely. She has a caregiver 4 nights a week to assist her with taking a bath, because no 96-year-old should be getting in and out of a bathtub without someone to help her. And she decided she didn't want me seeing her tush, so we hired a caregiver. I set up her meds in a reminder box, so I know she's taking them the way she's supposed to be taking them. During and after the hospitalization, she had to relive all that had happened. She had to come to terms with her oxygen dependency. That was a hard one. And we talked about it a lot, and I said, you learned how to use a walker so that you could get back and forth. Not the only one with a walker. No, I'm not the only one with a walker. And I said, I bet you're not the only one with oxygen. Well, she kept telling me she was until she went to the dining room and noticed that there were several other people with oxygen. One of them even came up and said, oh, you're a member of my club now. So the additional support of family and paid caregivers, both in the hospital and at home, prevented the delirium. And supportive caregiving with weaning off allowed her a readjustment lifeline. So after you get someone home after a hospitalization, you need to make all the necessary follow-up appointments. You need to reconcile the medications with the primary care doctor and maybe consider some baseline testing. You need to be a super advocate for your loved one. Please, please, please do not be intimidated by professionals. Remember, you're paying for them the same way you pay your plumber. If you expect the plumber to explain the cause and cure of the drippy kitchen faucet, expect an understandable explanation from the medical profession as well. If you don't understand something, ask them to repeat it. That way you can explain it to your loved one. Do not be pressured to move your loved one to a higher level of care post-hospitalization unless you truly agree with it. Yes, if your loved one had a stroke and really has significant mobility issues, you need not to be returning them home probably. But in most cases, home is the appropriate thing to try. And I always tell people, try home for at least a month. Put a little extra support in if necessary. Then if mom doesn't rebound, she can always be moved to an assisted living or a skilled nursing facility. Some people have said to me when I say that, but it costs so much money for extra help. Guess what? Assisted livings and skilled nursing facilities are not paid for by Medicare. It is an out-of-pocket expense, and that's $6,000 to $10,000 a month. So instead of paying the skilled nursing facility that money, try mom at home. One or two things happen. She's either going to rebound, she's going to become reoriented, she's going to adjust, and she's going to go back to her happy life. Or she isn't. And if she isn't, that month of help will allow you and the rest of the family to look at the next level of care so that you're making the best decision for mom, either now or whenever it happens. So bring mom home, give her a chance. If your senior doesn't bounce back to that normal mental baseline, consider seeing a geriatrician and have a full medical evaluation. Geriatrician is someone that specializes in old people, just like a pediatrician specializes in young people. So also you might want to see a geriatric psychologist to have a neuropsych evaluation. Let's see what's happening. Is it dementia? Is it delirium? And how can we best help mom? Thanks so much. Hope that answered some of your questions.
We have actually a few questions, 2 questions I think out there. The first one is, you mentioned several mental tests. What are those?
All right. The 3 tests that I talked about, one is called a mini mental. And it can be done by your primary care doctor. In fact, you could probably go online and pull one down and do it yourself. It's 30 questions. It takes about 10 minutes. It tests if people are oriented and also able to do simple mental functions. So it talks about what is the date, what is the day, where are you? Can you count back from 100? Can 3 objects, can you repeat them? And can you remember them 5 minutes later? So any primary care doctor, you want to do ask them to do a mini mental for mom. We routinely do mini mentals. All of our caregivers are supervised by nurses, and our nurses do mini mentals on every patient. That way, if they're hospitalized and someone says, oh, she has dementia, we can say, oh, no, she had a mini mental done this year and she scored 28 out of 30. She doesn't have dementia. She has delirium. So it is a nice simple baseline indication. Neuropsych evaluation needs to be given by a trained psychologist, and it takes about 3 hours. If you have serious concerns regarding dementia, it is a way to determine if there is dementia and gives you a better indication of what kind of dementia it is, whether it's Alzheimer's, Lewy body, vascular. There are lots of different kinds of dementia. And then there's also what is called a confusion assessment method, and that's also a 10-minute test that determines people's confusion level. So those are 3 tests that you might want to consider having done.
Thank you. All right. The last question is, I suggested help when my mom was in the hospital last year and she said no. How do I get her to change her mind when that happens again?
Well, I always say when you're dealing with seniors, when you're dealing with your children, when you're dealing with your husband, sometimes you just need to assume the sale. What does that mean? That means don't ask for permission. Simply state what is going to happen. In other words, you say, I talked to the doctor, Mom, and you're going to be going home in about 2 days. But the doctor said in order for you to go home, you need to have help for the next 10 days to 2 weeks. Not forever, just for the 2 weeks. Now, you might want to tell the doctor you're saying that so he doesn't contradict you when he comes in and you aren't around. And that's sometimes a good way. But always assume the sale. Say, this is what's going to happen. You're going to go home. You're going to have a caregiver during the day. We're going to live in, just like I said to my mother-in-law, we're going to have someone live in for 5 days so that you get used to this oxygen. I don't want you tripping on the cord, falling and breaking a hip. So we're going to have someone here and then gradually let them know how you're going to wean them off. At the end of 2 weeks, you know if you need to continue it. And quite frankly, they do too. And the other thing is if in the weaning off process, there's going to be certain things that they maybe do like having someone do the laundry. So when we were getting down to it and I said to my mother-in-law, I'm really worried that you could fall now that you have this oxygen tubing. And if you fall, you're going to break a hip and we don't want surgery. And she agreed, I don't want surgery. Said, so someone needs to be here when you take a bath. I said, do you want me or do you want a caregiver? And she said, you're not looking at my tush. I said that we're getting a caregiver. And so she was okay with that. She had a choice, me or somebody else. And part of that is I work with people with dementia. Don't ever give people a choice of yes or no. Do you want to wear the red dress or the blue dress? Do you want me to help you with the bath or do you want a caregiver? And one client that we have that's 102, we simply go in twice a week to help her with a bath, and do her laundry and housekeeping. And when I first met her 4 years ago, and I said, they'll help you with your housekeeping, she said, I can do my own housekeeping. I said, Lucille, you're 98. Why do you want to? And she said, you're right, I don't want to. And then that was the end of the discussion. So phrase it, give people choices, let them know there's an end in sight. But when they're coming home from the hospital, make it a condition of their release, and then you'll get the buy-in, because they all want to go home. You can go home with a caregiver, or you're going to have to go to the nursing home for rehab. Go to the skilled nursing facility, go home with a caregiver. I'm picking going home with the caregiver. So I hope that helps the next time you have to do that. And I hope you don't have to have your mom in the hospital again this winter. Thanks so much.
Great. Actually, that leads us into our next webinar. Save the date for November 9th, 2016. And our topic is Having the Talk, Assisting Seniors and Their Family in Accepting Additional Care. We hope you enjoyed this webinar, and we'll send out a link to the recording. Have a great day.